Hello, I'm Kim Seok Hyun from Pusan National University Yangsan Hospital. It's my honor to report a heart transplantation case in a patient with complex heart-lung disease to Korean general transplantation. Despite optimal medical therapy, a 63-year-old man complained of shortness of breath, aggravating for more than 6 months. He was diagnosed with AFib and had a permanent pacemaker implanted due to sinus dysfunction. In 2020, his dyspnea gradually aggravated. Coronary angiography revealed stenosis at mid-LAD and CTO at RCA, leading to stent insertion at mid-LAD. Despite several months of medical therapy, his LVEF was 31%. In addition, he suddenly expectorated a large amount of blood and underwent bronchial arterial embolization. All antithrombotic agents other than aspirin were discontinued. Due to his heart and lung condition, he was recommended for a transplantation of both organs and transferred to our institution. The rhythm was AFib dependent on the pacing, and Kerr's width was widened to 164 milliseconds. An enlarged heart and bilateral pulmonary edema were observed in a chest X-ray. Echo showed the LVEF of 26%, even worsened compared with the previous study of 31%. TR was noted to be severe. RV contractility was preserved while slightly being dilated. His chest CT showed emphysematous change in the both upper lungs and pulmonary congestion and right-sided pre-refusion. In PFT, measured figures were indicative of severe obstructive and severe restrictive lung disease. His PaO2 was 52 millimeter of mercury, which is compatible with coronastatus 1. We determined that he had intermax 2 to 3 heart failure, probably pacemaker component superimposed on ischemic cardiomyopathy. Previous AFib was a worrisome factor as anticoagulation was withheld because of massive hemoptysis. As for lungs, severe obstructive and severe restrictive ventilation was also a major concern. This multidisciplinary team discussed 3 treatment options. The first option was tricuspid valvuloplasty with CRTD insertion and LAA closure. However, doing all of this at once is not applicable in the Korean National Health Insurance System. Even if it happens, the patient risks bleeding from the antiplatelet agents. The other 2 options were transplantation. Taking PFT results into account, it's easy to conclude that he needs lung transplantation as well. We performed the cardiac catheterization under the dobutamine infusion. The pressures in the right heart chambers were elevated. Mean PAP and pulmonary artery wedge pressure were as high as 41 and 33 millimeter of mercury. Pulmonary vascular resistance were 3.2 Wood unit. This is the hemodynamic definition of pulmonary hypertension published in 2015. Our patients' numbers did not perfectly fit in isolated post-capillary nor combined pre- and post-capillary pulmonary hypertension. However, we concluded they strongly imply the congestion from the left heart disease. Thus, he is well suited for heart transplantation. Furthermore, the median survival of heart and lung transplantation is 4.5 years, which is much shorter than 12.5 years of heart-only transplantation. It would be much better if the patient could get heart-only transplantation. Moreover, the patient's blood type of AB positive is especially favorable for the waiting time. As we expected, after a short period, he received a donor heart from a 57-year-old man. The surgery was uneventful, and he was successfully extubated after 10 hours. X-ray showed a resolution of congestion. Fortunately, no signs of RV dilation nor compromised contractility were detected in the echo. Interestingly, there was a big improvement in the serial PFT follow-up. There was a dramatic rise in FEVC and FEV 1.0. The recovery speed for FEV 1.0 was faster than that of FEVC, but eventually the recovery of FEVC caught up, returning the ratio to its prior value. Along with the improvements in the test results, his clinical symptoms also resolved. In conclusion, airflow obstruction is a typical feature in acute decompensated pulmonary edema, uh, while restrictive ventilation predominates in a chronic stable heart failure. Uh, and this restrictive ventilation is reversible if heart transplantation is done. When distinguishing the clinical group of pulmonary hypertension in a patient with combined heart and lung disease, cardiac catheterization can be helpful. This clinical situation is challenging as some results are exaggerated and masked by other conditions. The lesson from this case is that meticulous investigations, including imaging and invasive tests on the patient's disease status, are warranted for differential diagnosis. Thank you for listening.